Hi everyone, this is case 6 debrief. Sorry, it's a typo here. Anyway, good job on finishing up the last case strong. I've heard a lot of good things from your facilitators about how you guys are doing for today. Just again, have a few things to share and discuss in the debrief. Again, hopefully it's not going to take too long. But the first thing I just want to share with you guys, hopefully this would be a good resources for you when you go into rotations, because it might come up a lot. And it is very important to give a summary in terms of how we treat hyperkalemia. There's a lot of options like I have listed here. And the important thing to know about treatment hyperkalemia is to know the mechanism of action. Okay. So because it can help you to decide in terms of which treatment to choose in specific setting. So for example, in this case, the patient is having ACLS, correct? So in those critical acute emergency setting, you want to give a treatment that is going to be working instantly, right? And have fast onset. And a lot of it is going to be your intravenous medications, or sometimes, it can be given IO if they don't have IV access, for example. So a lot of times, you're going to be looking for your either sodium bicarb or insulin regular, and know the mechanism of action. Okay, so those two do not really excrete the potassium from the body. It only shifts the potassium from the blood to the cell, so that we don't have a hyperkalemia anymore. But again, after you resolve the hyperkalemia, after you resolve the cardiac arrest, you want to make sure that you are going to, give another treatment to excrete the potassium. But at this time, in the critical setting, you need to give them, the IV medication, either the insulin regular, and remember to give them dextrose. This, you want to prevent hypoglycemia in this patient if you're giving insulin, or sodium bicarb. You would typically see calcium chloride, less like gluconate. You typically, chloride have a faster onset. But you would typically see calcium chloride being administered because it doesn't have anything to do with the potassium movement or excretion of potassium. It helps to antagonize cardiac conduction abnormally, so stabilize the heart rhythm essentially. So those are kind of like the three emergency hyperkalemia treatment that you would typically see in the ACLS setting or cardiac arrest. There are other options such as your albuterol, but again, when somebody's having cardiac arrest, basically they're dead, right? Their heart stops working. You're not gonna have them nebulize something, right? Or like have them take something orally. Furosemide, they're not gonna, the mechanism of furosemide is that, it increases renal excretion of the potassium, but when they're unconscious, they're not going to produce urine at that time, right? And it takes some time for the patients to, excrete their potassium. You want something very, very, fast onset. Make sure like the potassium is out from the blood, immediately. This, the other ones are probably good for more long-term, or like after resolving the cardiac arrest, post-cardiac arrest care. When you start kind of thinking about like, okay, what do I need to do to make sure they don't go to cardiac arrest again? And this, a lot of this are going to be excreting potassium from the body, right? Because they have, of excess of potassium in their body. So some of them, like I mentioned, the furosemide, it's excreting the potassium through urination. One thing to remember, if they're having a bad renal function or like even on ESRD, that's not going to work, right? Obviously, if they're anorexic, they're not making any urine. Sodium polystyrene sulfonate, or KX brand, or other brand called Lacalma or Pateromer. Those you can take orally, and it can increase secretion of potassium as well through fecal loss. All of this thing also, expect the patients to have a good oral intake and also absorption. And what they do is they bind to potassium on the food that they, they take. So a lot of times it only works when you're, having somebody eating the potassium, eating the meals, and then administer it with the meals essentially. Lastly, if they can't make urine, they can't take PO, it's like a last line, they might even do hemodialysis to get rid of the potassium. Albuterol-wise, I rarely see it as often being used for hyperkalemia treatment, but it can be used as well. It's not permanent, just because it acts like the sodium bicarb or the insulin. It just shifts potassium from blood to cells, so it doesn't really do anything. You can't really use it in acute setting or ACLS setting. Afterwards, even if you use it, you don't really get rid of potassium. So I rarely see albuterol as much. But knowing, so the important things in terms of hyperkalemia treatment is knowing what to choose for in special settings, and the mechanism of action. So it helps you how it works and then what you need to do in terms of making sure we're optimizing the treatment. Second one, I'm not going to go over very details, but in Debrief 5, I go over the vancomycin dosing, initial dosing, or monitoring with trough monitoring. Again, a lot of hospitals are using AUC now, but for patients who have unstable renal function, a lot of times the hospital are still recommending the trough monitoring instead of the AUC. So, and it's also in the instruction to have you do the trough monitoring instead of the AUC. So I'm expecting everybody to do the trough monitoring, giving the dose based on your calculation with the trough monitoring prediction. And if you need to go over your pharmacokinetics for calculating the trough or calculating the dosing based on trough, please refer to case debrief 5. Just want to clarify, there might be some error in terms of the case key, and some, of your facilitators might be providing some information that might not be updated, and it's all my fault. Don't blame your facilitators. So for those patients, because she is on the doxorubicin and the cyclophosphamide, essentially, if you look at the NCC and anti-emesis guideline, she is, because she's on the combination of both two, the regimen is actually causing high emetic risk. So basically, you would go with the high emetic risk regimen instead of the moderate risk. So just want to clarify that, and just want to make sure that everybody knows on how to follow the guideline, how to follow the algorithm in that part. Some clinical pearls. I have some questions about or like some kind of grading difficulties in terms of some students might be calculating the current clearance, because the current clearance that is calculated, depends on what way you use. It is borderline at 30, and if you choose Savapine, for example, their cutoff for certain doses are at like about either less than 30 or like above less than 60, 30 to 60 essentially. So some students might be recommending lower dose versus higher dose. So in the real practice setting, so basically you would try to see the clinical, use your clinical judgment essentially. And I know like you guys hasn't had a lot of clinical exposure, so I'm not going to ding you on this case. If you choose one over the other, that's different than what's expected. As long as you know how to calculate your current clearance, adjusting it based on the current clearance, that's what I expect for this case. But in the practice setting, you might see the patients being given maybe a higher dose, despite having a renal function less than 30, for example, right? And the way the dose are being selected or decided is based on their risk versus benefit, right? So what is the risk of patients getting the adverse events, right? And how really bad is the renal function? Is it like AKI or is it their baseline renal function? And also, how bad is the infection? Do we really need the patient to get like optimal doses of antibiotic, and not risking them to get under dosing, right? So those are a lot of things that will be considered in the practice setting, and hopefully you will get those experiences once you get to AbbVie. So just kind of like clinical pearls. And last clinical pearls is also, antibiotics. I know everybody hasn't got exposure to sepsis in clinical setting, but just be reminded there is, it's kind of like, you know, when somebody get heart attack, there's also like, you know, or like stroke, there's door to needle time that, you know, that the hospital has in terms of goal and on those timing. Same thing with sepsis and antibiotic administration. So typically, if you look at the guideline, when somebody come in with sepsis, an antibiotic is, you know, ordered, the door to needle typically is within 1 hour, because it's an emergency setting, right, where sepsis can kill people. So they want to give the treatment as soon as possible, as soon as it's ready. And a lot of times antibiotics, it needs to be compounded and everything else, so it takes time. And when, you know, pharmacist side, we need to make sure the doses that are adjusted. So we need to take some time to make sure, you know, the doses are correct and compounded. So a lot of time, you know, we should be reminded the urgency of certain medications in terms of, okay, what to prioritize first. You know, can we really like make it urgent, and if we need clarification on the dose from the doctor, or like, you know, the compounding part, maybe we can make it stat from the compounding aspect, to make sure we make that first before the other drugs that might not be too urgent in that case. So something just to kind of share. But otherwise, that's pretty much for case 6 debrief. It's been great having you guys for CB4 again after CB3. So hopefully the cases for the semester have been really helpful to get you in the mindset of applying it, and kind of introducing how the clinical practice will look like. And I wish you all the best for ABI. And please keep in touch. I'm always happy to, you know, hear back from my students once they get to ABI, and even after you graduate, and keep, you know, keep connected. Thank you, and we'll look forward to see you for OSCE. Bye-bye.